Hello, everyone. Thank you so much for being here today. While we allow for everyone to connect to the webinar, I am going to be providing a few instructions for everyone to be able to use the interpretation option. So to hear today's presentation in Spanish, please go to the interpretation tab on your Zoom panel and click Spanish. You can also mute the English speaker voice, clicking mute original audio. Now, we will review a few housekeeping items. Today's event is being recorded and will be made available publicly through our website and other media channels. For today's webinar, all participants will be muted. Please make sure your computer speakers are turned on and up to hear today's presentation. If you're having technical issues, please send a message to the Hispanic and Latina Behavioral Health Center of Excellence on the chat box. If you have a question for our presenters, we ask that you use the question and answers tab on tool. Simply type your question and hit send. We can address questions to the presenter at the appropriate time during today's presentation or at the conclusion. We will be sharing a copy of today's presentation in PDF format through the chat box. And we will also make a copy of today's presentation available to be downloaded through our website. You can find it under the name of today's event, and a recording of today's webinar will be posted in our YouTube channel. Please complete the evaluation at the end of the training. The evaluation will help us know more about your opinion and thoughts about this presentation and what other topics and training would you like to see offered. A link to the evaluation will be shared through the chat. You can also scan the QR code at the end of the presentation to complete it. Now, our mission is to advance and support the sustainability of behavioral health equity by promoting community-driven, culturally grounded, and person-centered prevention, intervention, multiple pathways of recovery, and recovery supports for diverse Hispanic and Latina community. And we strive to accomplish this mission through the development and dissemination of culturally informed evidence-based behavioral health information, providing training and technical assistance, and supporting the growth and expansion of the behavioral health workforce that serves the Latina communities. Now I am going to allow Dr. Colon, who is our speaker today, to give a little bio of himself and then begin the presentation. Thank you so much, Dr. Colon, for being here today.
Thank you, Paula. And yeah, introduction will be fast. So I'm Hector. I'm Dr. Colon Rivera. I'm an addiction, an adolescent, and a general psychiatrist. I'm in Philadelphia right now. For the past probably 5 years, I've been working with Hispanic communities. I would say probably 90% of my patients are from Hispanic backgrounds. Probably from 90%, about 60 something are from Puerto Rico, so they're Puerto Ricans. And I work in different settings. Main setting is outpatient, but also work inpatient. I cover ER, the emergency rooms at times, and I do a lot of consultation for rehabs through telemedicine. So I'm the medical director for APM, which is Asociación Puertorriqueños en Marcha. And it's a nonprofit here in Philadelphia. We have different departments, including foster homes, housing, and school. So most of the social determinants of health. I also work for University of Pittsburgh, doing telemedicine and running a PhD program, or intensive outpatient program there from Philadelphia. So today we're going to talk about integrated collaborative care, especially those for Hispanic communities. This is a topic that has been around for years, but we have seen more and more of the need due to, different reasons. There's the stigma, lack of access, primary care being the main ones, seeing patient for mental illness, or the first one, usually diagnosing a mental illness or a mental disorder, or even a substance use disorder, because they see the patients before the patients see a mental health professional. So we have a few objectives for today. We're going to talk about mental health and substance use trend in the Hispanic and Latin communities, and that's important. I mean, the trends change probably every cycle, every 5, 6 years, sometimes every year, depending where you are, also the states. And if you are from Puerto Rico, well, the trends are different. Even though we're talking about similar communities, we're going to define what integrated healthcare is and integration of cares and what's the evidence behind that. We're going to describe the prevention, assessment, and continual integrated behavioral treatments into primary healthcare settings, especially for Hispanic and Latin patients. We're going to talk about various integrated care models and multidisciplinary practice. Some of them are when you have the psychiatrist locally there, or the use of technology these days is pretty common, especially after COVID. We'll be using more and more technology, and I mean, and AI, right? And this is a hot topic these days. If you're following the stock market or you're following healthcare in general, there's a lot of startups using AI or artificial intelligence in the healthcare system. And of course, I mean, it's important to talk about barriers and things that we can do to improve. In terms of payment models, I'm going to mention a few of them. I'm not going to spend too much time on billing, reimbursement, and the coding for this type of services. That's kind of that's not the center of this presentation, but of course, future presentation can include more of that. So what do we know about mental health and substance use trends in the Hispanic Latin communities? I'm in Philadelphia, so there is a lot of drugs in Philadelphia, and probably you see that on the news. We're always in the first, probably top three areas with substance use, and we are about close to 20% Hispanic in Philadelphia, so 15, 18% at the moment, but getting to the 20%. So there's a lot. It's a lot of community. Of course, we have other states with similar populations, like maybe New York, Texas, Florida. California has a lot of Hispanics, but here in Philadelphia, it's a lot of Puerto Ricans as well. So we're pretty used to see patients from Hispanic backgrounds. Today we have about 600 attendants. I mean, right here. I don't know if you guys are working with Hispanics right now, or planning to, or have in the past, but right now we're expecting the population to keep increasing, right? And it's not stopping. I mean, the forecast for Hispanic population in the United States from 2022, was 2 years ago, to 2060. We see how the population in millions is going to increase. We're talking about right now, so we are in 2022 by 2025, so it's about 60 millions, right, of population in the United States, and that's probably almost double in the next 40 years. And of course, with that, more patients, and we see only about 3 to 5% of the workforce being Hispanic already, to treat Hispanic communities in terms of cultural humble, being cultural humble or cultural competent to do so. I just picked out Chicago, Illinois, because we have a presentation like this with people from Chicago not that long ago, and you see how Hispanics is probably a third of when you compare to just Caucasians, and these numbers are increasing. And of course, we see a lot of disparities in terms of Hispanics, 50% more likely to die from diabetes. So it's not only mental health and substance use disorder. And of course, we have a lot of comorbidities, asthma, diabetes, hypertension, things like that. I mean, a lot of COPD that has been caused by or after the substance use or mental health, or they have some kind of I would say confounding factors around these physical and mental illnesses. I would say in adolescents, I see a lot of kids starting at the age of 10. There is a lot of suicide ideation these days. 1 out of 10 reporting having an attempt of suicide in their lifetime. So Hispanics, in terms of drinking, the binge drinking rates for the past year are the highest compared to other racial ethnic groups. And Puerto Ricans have the highest overall prevalence rate among the Latino ethnic groups that this story presented. And when we talk about Cubans, we talk about Mexicans, we talk about other ethnicities within the Hispanic groups, and Puerto Ricans are usually the one with the highest prevalence uh, rates of substance use and mental illnesses. Um, 1 out of 6 Hispanic with HIV are unaware they have it. This, those numbers talk a lot about we need to do a better job in terms of prevention and assessment of these patients when we have them. And a lot of that, of course, the primary care physicians could work in a better way, and also in a better way to work with them in terms of either referring or creating these models like collaborative or integrated models. Some other societal issues, according to the census, we saw this. I mean, we're going to keep increasing. Hispanic communities are going to keep increasing. About 60% of U.S. Hispanic Latin people have a Mexican background. It's easier for Mexican to cross to not need to cross the ocean or water or travel in planes. I mean, they can just cross and walk through the U.S. So it's a little bit easier for them. 19% of Hispanic people in the U.S. Live in poverty, and we know. I mean, we're going to talk more about barriers. So, of course, of health insurance, not having the means to travel, having multiple jobs, and those are all limitations for our Hispanic communities to look for help. And of course, the Latinx and Hispanic people are highly concentrated in a few states in the U.S., which I just mentioned a few of them, and usually on those states, yes, we have more of the clinics, Hispanic clinics, but we have seen that in the last probably 5, 10 years, these have been closing. So even though we have more concentrated on these few states, uh, the ones we used to have, are closing, and there are only few. In Philadelphia, it's a great example. We do have probably 3 or 4 Hispanic clinics that treat mental illness and substance disorder. But in the past, probably we have probably 5 or 6 or more. So these have been decreasing. Um, and there is some perception of mental health. It creates some shame in the family, and there's a lot of stigma, especially for the machismo in the man figure, and because they need to be, the person in charge of the family. So either they don't have the time, they don't feel they have time, they don't feel they have anything, and it's not until the end, right, when they have no option, they're really sick or suffering, or they go to the ER, that they start looking for help and accept treatment. Um, Immigration was a huge topic on the last elections, and it's going to be a huge topic for the next 4 years. And we see how you know people that come from immigrate from a different country versus the one that are born here. There's a big difference in terms of health and substance use and mental health. Usually, people that immigrate and they keep their traditions and they keep the language and they keep their culture. They do better and have more support than people that are born here and tend not to be part of the tradition, culture, and get be part of the family or community, Hispanic community. They do a little bit worse, or they are at risk of having a more severe disorder. Um, and I mean, they call this a phenomenon, the acculturation, right? So because it causes a lot of stress to move from different countries, and you tend to get support from the communities that you have here. That's why Hispanic tend to stay on a few states, because there are already Hispanic communities established on those states, and they get support. So again, so a little bit of more numbers in terms of you guys to get familiar with what are the disorders that are most common in the Hispanic communities. So alcohol disorder is a big one, and depends on the state. For example, in Puerto Rico, you start drinking at the age of 18. The other countries, Hispanic country, you start drinking at the age of 18. It's pretty socially accepted to drink even before that. There's marijuana use similarly to US. I mean, that's a pretty common uh, uh, issue that started pretty early. I mean, people start smoking marijuana this day around 13, 14, most of my patients, sometimes before that. And pain relievers and use disorder is the third one most used. Heroin is not as hot in the Hispanic communities. I mean, we do have a lot of people with opioid use disorder in the US, but it's not as hot as alcohol use disorder because it's more acceptable and the marijuana or cannabis use disorder. Um, Stimulants, I have seen an increase, however, not to the point of getting to these big numbers. But yes, there's an increase in the use of meth, specifically meth, and which is methamphetamine, and cocaine use is kind of stable, not so much as an increase. And the same numbers for adolescents too, right? When you see the monitoring the future data, their heroin is not hot topic. People, I mean, kids don't like the feeling. They're more into probably using opioids, painkillers, and stimulants, and of course the alcohol and binging. So I'm just going to show this because this measure, this is according to the a national survey done in 2021. Which it shows that, I mean, so our disparities are not better, they're getting worse or have not changed, which is pretty sad. We need to continue to talk about these topics, um, and be more mindful that we need to talk more about this. I mean, for both adults and kids. Um, Suicide deaths per 100,000 population, I mean, that has been better. And I think because of the creation of ads, a lot of promotion, a lot of uh, the new hotlines, lifetime hotlines and numbers and help, the creation of 988 and the chats and technology have improved that a lot. We also have better service and different rules about doing the service in every time you go to the ER, for example. Now you get a survey about safety and suicide ideation. Also, when you are admitted to the hospital, that follow up, if that trigger a positive result, they usually put a consult for psychiatry. So that has changed through the years, and I think we're doing a better job in general, not only for Hispanic communities, but in general about suicide assessments. And of course, we improve that. We improve the deaths from that. So when we primary care and why we talk about collaborative and integrated care and what it is so important. So this is a hot topic. My wife is an internal medicine doctor and I'm a psychiatrist. So this is something that we talk at the table a lot. I mean, what's the best model? How can we improve this, right? Access to mental health treatment from a primary care perspective. So why is this relevant? Well, behaviorally related physical complaints, I mean, they are uh, predominant in the primary care settings. About 70% of primary care visits are related to behavioral health needs. And if you see any data out there, even in an emergency room, we see that most of the presentations for any behavioral change has to do either with drug and alcohol problems or anything that happened at home that was socially triggered. You see that in a lot in kids, for example, that have a different change of behavior when mom take their phones from there, or there's something happening in school with bullying and they caught themselves. So all these emergencies are behavioral health related. And we have not seen a decrease, but an increase on these presentations. The same happened in primary care settings. So 1 in 5 Americans are affected by a behavioral health disorder during any given year. 50% of our behavioral disorder are treated in the primary care. And in the last years, we have seen it more and more and more for different reasons. I mean, I think COVID did a big dent on society, and we've seen a lot of more anxiety in people, also the finances and the political changes have created a little bit of wave, and we're seeing more behavioral health in primary care. And I keep saying ER, emergency room, because for me is a place that we can do a better job in terms of collaboration with other and multidisciplinary collaboration with other doctors. On average, 97% of Americans need to change one or more health behavior or regain health. And I think the APA, American Psychiatric Association, have done a good job doing surveys every month about behavior change, like the changes due to the weather, like affective behavioral, seasonal affective disorders, things like that. And I think that's really important to keep doing those surveys, because that help, not only psychiatrists, but also primary care to understand what all these society changes and what they're seeing in their offices. So what needs to happen? I mean, how can we transform our healthcare, and what has been going on for a couple of years now? So in terms of Hispanics, we are less likely to go or to have even a primary care provider. And this is pretty common. Same happened with African Americans and of course the Hispanics, right? We do not like to go to the hospital or to our primary care physicians. I can talk about, my patients, for example. They probably go every year, sometimes just once a year for their, physical exam. My adolescents probably only go because the school tell them to go for
Wow.
Hello? Okay, yeah, I heard a voice. I'm not hallucinating. Okay, so also, I mean, when we talk about Hispanic communities, they also prefer to see someone that speak their same languages or understand the culture, and this is really hard to do. Is there again? I think I mentioned this. When you compare 80% of the population versus only 3 to 5% of the health professionals are Hispanic. So in terms of workforce, that's a different topic, but that's something to think about as well. And team-based care, which is what we're talking about today, integrated behavioral health assessment and intervention in a primary care setting, is a solution for this. And of course, I mean, yes, there are a few things that have improved, and I feel health outcomes in people that do participate in primary care, and they see the primary care. So we see a better improvement in the past 20 years compared today versus 20 years ago. And there's a lot of grants that help with that. Grants that you can see patients without health insurances. A lot of grants about immigration status and not needing to be residents or having any type of visa to be seen in the hospital and things like that. That has changed a lot. So there's a lot of more help. So what is the traditional model? And probably most of us work in this type of model, right? The traditional model where you have a PCP and a patient and then a psychiatrist, right? Like it is either in a different county or it's telemedicine these days, but doesn't belong to the healthcare setting of the same office, right? They're usually consultants or referrals. And they usually are specialists, right? As other insurance call them specialists, so they're not in the primary care setting. So collaborative care model was created a long time ago to fix this. And it's well used, really well used in the VA system and Veteran Affairs system. That's when I first was first trained on the VA, and collaborative care it work wonderful in the VA system. And so the collaborative care model is, you have a someone center. I mean, there's something called a care manager, and this care manager, work with with the PCP and the psychiatrist and the patient, and they create a good a good relationship between them. So there are different ways of doing this collaborative care model. I mean, there is one that you have a local psychiatrist, which could be full-time or part-time, and the psychiatrist is part of the team. Also, I mean, people usually, or all the clinics, they use have a psychiatrist in terms of only for consultations. So it's not in the same office, it's in a different office, but they can connect when the patient is seeing the PCP, and they can collaborate and see the same patient. At times also work as I will refer you, and but the psychiatrist is part of the team. It's not like an outside referral, it's an inside referral of the same team. But the patient is seen in the different day, or but the time of waiting is a lot shorter because the psychiatry is part of the primary care setting. So again, there's a co-location system, a co-located service, and there's collaborative care, which is collaboration. But there's always a care manager that facilitate the connection. So, so collocation or collocated services, a behavioral health provider work in the same space that or close proximity to the primary care clinic. It could be in the same office sometimes. It could be on two floors up or two floors down, but it's close to the primary care setting. That we see that often used in the VA system. There's a collaboration that is the interaction between a primary care and behavioral health provider for the purpose only of developing a treatment plan for that client. And this treatment plan could be at the same day, at the same time that the patient is seeing the primary care physician, or a different time, but then they meet as a team and create a treatment plan for this client and coordinate care to meet the physical and the behavioral health needs of these patients. So again, comparing the two, right? I mean, traditional mental health versus collaborative care, location, PCP in the clinic, and the mental health is on different floor. Population is they have most of them have some usually a mental health diagnosis. It could be from mild depression to severe depression or psychotic with psychotic features and things like that. And when you have a collaborative care, it is mostly a problem focus and solution oriented with a patient centered treatment plan and goal. Due to the time constriction of both services, but you are getting a more complete treatment plan as you are, also adding the behavioral health to the physical health presentation. Um, in the treatment plan, in the collaborative care, the PCP still, I mean, is the main the leading part of the group, right? Of course, you have the care manager in most occasions, but the PCP is the one in charge of the case. So the behavioral health is there for consultation or to add to the treatment plan on the behavioral health issues. And the primary focus on the collaborative care is to support the overall health of the veteran or the patient on that situation, versus if you go to the traditional mental health treatment, it just treating the mental health symptoms, and then you refer something if you find any physical health situation and need more to be assessed. So and in this setting, we use a lot of the brief assessment tools, especially primary care. I mean, this day now, everything's automated and you have electronic medical records. When I was in residency, we were still using charts, like paper charts and writing. These days, you get a lot of notifications, flags, red flags. You're missing this and missing that, and it's pretty more. I mean, it's more structured. Give you, how often you need to, for example, do a PHQ-9 or PHQ-2 or a GAD. when usually when you go to a primary care, you get a PHQ-2, which is just two questions, and if that's positive, then you open up to a PHQ-9, similar to any PCP presentation. So you can use this brief evidence-based screening, and PHQ-9, PHQ-2, GAD. 7 and I did C. I mean, all this. I mean, craft. If you've seen adolescents, and of course, bias orientation, memory, and concentration assessment, and you focus more on the functioning of this client. Something I want to spend some time on is the challenge can be organized. How this is challenged, and only primary care physicians have sometimes 15 minutes to see a patient, or up to half an hour. So I recommend using the 5A's model to ask questions and organize your assessment. So any primary care physician that's listening to this presentation, I think this is the model is mostly a behavior change model that's used in primary care settings to address all the health condition and behaviors. And this help you to organize. And if you need to open up to a more collaborative care model, you can. And this can be applied for any product, not only behavioral health. So that's it. And so this help because, we see a lot of depression in primary care and in behavioral health, as we see, frequently recognized by PCP. If we're not organized, we can miss a lot of diagnosis or misdiagnose the PCP. That's why the collaborative treatment model really help primary care physicians, to add that mental health component to it. We all know that I trust primary care physicians to treat those depressions that are mild to moderate. One is, if we're talking about more about psychotic features and things like that, I think a referral will be better. So how this works? So let's say you have a patient that is depressed, right? So you introduce yourself, you clarify the reason for the visit here. So you talk about the situation, your chief complaint, and measure the goals of the patient. The motivation to change is something that we need to use. You guys know about motivation interviewing, which is not a treatment, but it's a tool, right, that we can use in these settings. Usually after that, in ways of assessing the situation, so we use the assessment that we talk about, especially PHQ-2, PHQ-9, or the GAD-7, which are pretty easy to do, pretty fast to do, and they give you a score right away, and you can you just put the patient in a different level, mild, moderate versus severe. And then you conduct a functional assessment. All this should take you about probably 10 minutes altogether. And then we can go to advice, which is identifying the patient solution. It could be medication, it could be therapy. We discuss options of prescription versus just waiting, versus monitoring symptoms versus referral. And we develop a plan. That's when you can do the motivational interviewing and take action. Then we go to the agree, which is engage the patient in discussing the options that you already talk about, and allow the patient to suggest new options. Things that he or she have tried before and didn't work, and of course, follow-up appointments may be necessary to discuss options further if that's the case. And then we assist with the implementation of one or more interventions chosen. Of course, this can be used with the primary care traditional model, or the collaborative care model with the psychiatrist part of the team, and the psychiatrist being present during this structured assessment. So the last part is arranging, and we arrange the follow-up visits can vary greatly between individuals, and this follow-up visit could be only with a mental health professional if we're only talking about behavioral health, or could be a collaborative model use of the follow-up. It could be both with the psychiatrist and the primary care, or it could be only with the primary care physician as the main lead of the team. Um, so So if the patient is not having a success after 2 or 3 visits and barriers are difficult to overcome, I mean, we probably I would prefer or recommend to refer directly to a mental health professional. And I'm not sure. I mean, yes, some of the mental health professionals that are part of the collaborative or integrated care model are able to see patients individually. Uh, Most of my friends that work in these settings, they only work with the collaborative care team for only this type of consult of being part of the primary care treatment plan and don't see patient individually. But there's a lot of models that do have both. So the patient works like a warm hands off, right? So the person, you already know the patient because you saw it with the primary care and you just follow up as a referral. So for me, that's the best follow up. Someone that you already know and met and was introduced by your primary care physician. Um, so prevention, assessment, and treatment, and the continuum of integration of behavioral health. So, uh, so when we have, I mean, I'm addiction psychiatry, so I see a lot of Hispanic and Latin patients with substance use disorders. So let's talk about a little bit of relapse prevention and primary care. So which is part of the collaborative model that we were discussing. And what's important is, uh, the structure of your presentation, and we want to just collaborate with the 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 multidisciplinary team and consider all the options to that client. And again, I mean, we know that probably almost half of the patient with relapse or have a substance disorder, they usually go to family practice. I mean, this study was back in 2015, and they identified that probably 44% of the general family of the people suffering from substance use go directly to the family practice, to the PCP, versus 20% go to psychiatrists and other specialists. Um, uh, uh, I mean, this could be pain management, rheumatologists. I mean, any specialist would be. Oh, I mean, I work with a lot of OBs as well in the mammies and babies groups and teams and units we have. So a lot of OB do identify, even dentists, right? I mean, do identify substance use disorder patients, and and they're the first ones seeing the substance use. Um, when we talk about, I mean, as we saw, I mean, in Hispanic communities, there's a lot of alcohol use. Uh, and one of the limitations we have with primary care physicians is how comfortable they feel prescribing medication for assisted treatment like MATs, for any MATs. I mean, we have MATs for alcohol, tobacco, and opioids, and they usually don't feel comfortable enough to start a medication for different reasons of barrier, access, and time. It's a big barrier there. They do a great job screening with a brief intervention that is part of the collaborative integrated care. And of course, medication prescription is lacking, and that's where referral or following up with the mental health professional comes in. Um, and there are different reasons for this. I mean, we have a lot of barriers on implementation of these models. There's a system level, provider level, and patient level uh, um, barriers. And is systemic barriers. It has to be within. I mean, it could be due to insurance, could be due to the government rules, could be because of the county rules here in Pennsylvania. So every county has different insurances and different ways of doing things and different budgets. So that could be a big barrier. Provider level information, the FSC perception, the attitudes of the primary care or any of the providers are seeing, I mean, it could make a difference. And for the patient level, I mean, how ready they're for change. But how do we overcome barriers? I mean, training, speed, implementation of pharmacotherapy is a good one, but no, it's not sufficient. Clinical support system, having conversations like this. Something I love is the ECHO model of integrating care or doing more the collaborative and training. And for you guys that I would recommend you guys to read more about the ECHO model. Usually is, you have a specialist in one topic and that specialist train primary care physicians in that specific topic, and those primary care physicians feel comfortable enough to treat that specific disorder or topic that the specialist is talking about. I mean, we see that a lot with HIV, for example, Hep C, substance use disorders, echo programs. Some of them have different names, like RAMP, for example, in rural areas is another one that some states have. And there's a lot of evidence-based models in the collaborative care and integrated care models for MAT in primary care. For example, I'm just going to mention a few here. There's Hub and Spoke model. There is collaborative opioid prescribing. There's a bunch around nursing care, like the Massachusetts Nursing Care Manager model. So, I mean, save this slide. I mean, research these models. When I was in Connecticut, we used a lot of the emergency department initiation of medication for opioid disorder, and this is a great one. I mean, you start patients with the health or mental health professional and the ER doctor in starting the patient on an MAT for opioid use disorders. So Save This Life is pretty good. Depending on the setting you work, you can use any of these models for primary care, starting an MAT or brief assessment for substance disorder or mental health in your practice. So discuss the integrated care models and multidisciplinary practice and the different healthcare languages. So there is a lot of services that integrate services. I mentioned at the beginning that I work weekends. I work in the emergency room and the inpatient units, and there is a lot of integration of services. Something that we use a lot is the consultation and liaison and the CL program, and that's having a health professional, a mental health professional on call or part of the team that help you answer questions, seeing the patient, and create a treatment plan for that patient that includes both primary care and mental health. The collaborative care, which is what we're talking about, integrated care, of course, the most used models and what I think the system is moving to. In the past, we talk a lot about patient-centered medical homes, which is pretty similar to integrated care. There's also person-centered care and shared care. In terms of CL, I mean, it's been around since the 50s. And it's just extending mental health services to medical and surgical inpatients. We also do it with the emergency rooms, and we see a lot of kids. We work pretty close to the OB team as well. A lot of postpartum depression and referrals come from that team. And I mean, CL in primary care have demonstrated better treatment outcomes and decreased costs. When mental health care is pretty accessible in primary care settings like the OB and emergency rooms. And of course, I mean, all this use a few elements of the collaborative care model, I mean, which are the routine screening for mental health and behavioral health conditions, the referral relationship between primary care and mental health providers, the routine exchange of information between providers, and technology have helped tremendously a lot on this. Most of the electronic medical records have like chatting options. You can link and add people from different teams to those conversations, so that really helps. We can have conversations more often at different times of the day. And you don't have to be there in person, so that really helps. And that helps primary care providers to deliver a specific mental health intervention using treatment protocols and different algorithms. And of course, I mean, there's sometimes we have in big system we have case managers that they facilitate the communication between the providers and the patients and the community and family members, which are pretty important for that patient treatment plan and improvement. We mentioned the collocation, which are when you have all these teams in the same location, and the referrals are done in the same system, which is, in my mind, the best case scenario when you have the specialists in the same system and you can share information without, keeping all the confidentiality possible. And of course, the integrated care model, which is a pretty comprehensive and coordinated team-based approach to care. Ideally, I mean, this model is at one side and includes both the medical care and the mental health care. Typically, we have a multidisciplinary team working together, often using protocols and evidence-based practice. And the more you work with the different teams, the better it is to create protocols and models within the integrated care, like, for example, CBT, focused therapy, like trauma focused therapy. We use a lot of prolonged exposure therapy as well. And of course, I mean, with technology and AI use, it's a lot easier to monitor and track patients over time. So it's really important. I talk a little bit about the patient-centered medical home. I mean, this is something that yes, we keep using it, but when I was in residency, it was like, this was the perfect plan, which is a place in the model that includes everything, the holistic person-centered healthcare. And it's often, team-based and comprehensive. And this is when you have all the teams, right, including advanced practice nurses, physical assistants, social workers, pharmacists, all the team, and they meet together and they create a plan for this person, and there is a lot of regular source of healthcare for a broad range of medical, mental health, and physical health. So really good. I mean, probably a little bit more expensive than other models due to the inclusion of more than one specialist and also nurses and PA, but it works. It works. The VA use it a lot too. And there's the person-centered or shared care, which is services that are responsive to individual patient preferences and needs, and the value of that is guided by the patient preferences. So in shared care, primary care and mental health professionals work together in a shared system in which provides maintain a treatment plan addressing all patients and share medical records. So you don't have to be part of the same system, but this is a shared care. I mean, our example is how the Canadians do this patient-centered shared care. I mean, there's a Canadian model that you guys can research. And the care management, a lot of programs for especially severe mental illness like psychosis and the PAC teams and things like that that works on the outpatient. Once the patient is discharged, they includes routine monitoring and assessment of patient, mostly focusing on psychoeducation, brief treatment, and adhering to medication, just to prevent these patients to have relapses on their behavioral challenges. And you have a supervising clinician, and the PCP, of course, again, is the lead doctor on the team. but always have this collaboration with other disciplines, and through the care manager, which is the one that communicates changes or treatment to the patient. Um, so uh, and I mean, case manager offer all this. I mean, it's a strong ties to the mental health supervision, assessment based, tracking, which is for me the most important, uh, uh, part of it, because we really monitor the patient on these models. And the result is you have a better symptom and functional outcomes, greater adherence to treatment, especially for people with severe mental illnesses, and you have all the assessment, the triage, you have referral management if needed, and support the patient self-care. And is usually care managers are usually nurses or social workers, but of course we can have psychologists and other disciplines on this as case managers, depending on the severity and the program. Um, and what I like the most is patient self management, which is really important, especially for in the Hispanic communities, right? And case managers for the Hispanic communities, at least for my patients, they are bilingual, most of them, which is really hard to find. But there are a lot of programs that the case managers are bilingual, and they keep communication with families and the patient themselves. So I mean some of the models out there and the evidence base behind this, and there's something called the Ahead program, which is all payers and health equity approaches and development models, and it was designed to improve health equity by increasing investment in primary care, integrated behaviors. Um, and there is a lot of data out there in terms of substance use and the use of MAT in primary care settings for a better care management and behavioral health integration of treatments. This was a trial done in 2015. And it was on a prescription of addiction medications after implementing chronic care management for substance use disorders in the primary care. And of course, this one was one of the first trials done. Then after this, they did follow-ups. There is the Ahead as a Summit study, which is more about collaborative care for opioids and alcohol disorder in the primary care. This is from 2017, and it was done in California in a very qualified health center. Patient with alcohol and opioid use disorder, focus on clinical applications on screening, brief intervention, referral to treatment for motivation interviewing or CBT, but also using buprenorphine and the Vivitrol or naltrexone acting injections. And they found that, well, takeaway one is both organizational readiness and collaborative care can facilitate the implementation of these medications and treatment for people with opioid use disorders in primary care settings. And it, of course, increase outcomes of the patients. Collaborative care leads to increased adherence and access to primary care recommendations and of course, follow-ups. And patients who received any treatment with collaborative care model did better, and regardless of the type of treatment. So it didn't matter if they got Vivitrol versus buprenorphine. It were part of the collaborative care model in the primary care setting. They did better. And of course, I mean, there's still barriers, but despite the perceived barriers, treatment can be successfully integrated in the primary care setting. So a little bit more about, I mean, some of the cases that have dealt with in terms of implementation and facilitation of these models. So usually, quick case here, when you are consulting with psychiatrist working in an outpatient setting, I mean, there are not a lot of people prescribing MAT in the primary care setting or long-acting injectables for psychosis. We usually respond by the medical doctor or the medical director is to refer out. So if we have a collaborative care agreement or a collaborative care model or integrated care, the response will be a lot different, right? And of course, the challenges stay the same. We don't have enough psychiatrists or addiction specialists. Family medicine are really pretty busy. They need mentorship from behavioral medicine in most cases, especially when we deal with severe uh, mental illnesses. And we mentioned a lot of models, but I think the collaborative integrated care models, help with what the primary care physicians are looking for, what they appreciate, which is, doing the work in this amount of time. Also, the communication of, I don't know how many of you guys work in the outpatient. For me to find a primary care physician on the line, it's really hard, especially when you are working from 8 to 5 p.m. I mean, they're really they're busy with the patients. Same with the psychiatrist. I mean, finding a psychiatrist and making an appointment with a psychiatrist, it takes 3 4 months sometimes. So uh, we do respect these kind of models because they create a solid communication process and correspondence between the primary care and the physicians and mental health physicians. So the quality of more communication between treating these physicians is better, and of course that is the improvement and quality of care provided to the patient improve. Uh, in terms of reimbursement, I said I'm not going to talk too much about this. I mean, codings have changed through the years. We have codes right now for integrated care and collaborative care, and usually almost all healthcare decisions are done in terms of fee for services. And again, these different models have. I mean, there's some hybrid models, but I mean, I think we're moving to the model of being more doing more prevention than just treating. So we need to improve the terms of monitoring uh, the improvement, right, of the patients, showing that the patients are improving. But right now, fee for service is the most used. But of course, with the rising of health costs and things like that, we need a better model. But that's a different topic. So this is just a type of mentioning most of what we had mentioned now with the use of technology and eco treatment of primary care and behavioral health providers improvement due to that. Uh, in, we need still a lot of facilitators for this to work. We need better tracking of behavioral health care outcomes. We need more training of primary care providers about BH conditions, and of course the opposite is the same. We need better tracking of a physical condition in behavioral health settings. And actually, there's other models that include the primary care physician in a BH setting as well. I know it's not a topic for this conversation, but there are models like that. And I mean, these are the facilitators that we need and still need. And of course, the barriers are still there, which is the workforce shortage, which for me is the nightmare of the nightmares. I mean, it's the hardest. As a medical director, it's really hard to find, people that want to work in the outpatient setting, also in a community setting, that are bilingual, and is hard. So so yeah. So with that being said, I mean, some of the barriers are integrated care, and these models are, some clinicians perceive a loss of autonomy with their patients because we're talking about, a team deciding. In most cases, some plans are a lot different than what you're going to do or what you perceive was the best for your patient. And all the feedback need to be taken to create a treatment plan that includes all opinions and health professionals styles and recommendations. Um, of course, the training is a big deal. I mean, mental health training for primary care physicians needs to happen, and that takes time. It comes with a cost to the system. There is a lot of the time constrictions in primary care settings or behavioral health settings. There is a lot of lack of agreement as to who is in charge, even though the collaborative care models and integrated care were created for the primary care physician to be in charge or be the lead at least. Um, and there's the reimbursement part, even though we have done a lot of work on that situation, and we're getting better reimbursement, and we have codes right now to for that. Still, we have a lot to do, a lot of work to do on that. I mean, I don't think the reimbursement is fair. I remember that we're including a lot of minds, a lot of different disciplines that have different rates. So it's really hard just to combine all that knowledge in one code. There is a lot of issues with social workers limited training, getting interprofessional team-based practices, or any of the care managers, not only social workers, but any participant of this in this teams. I mean, we don't receive a lot of training in how to work with other teams or with other team members, or how to be a team player, to be a good team-based practice that is patient-centered in a primary care setting. So that has to improve. So I think I'm running out of time. So I'm going to open the microphone to questions or in the chat. I'm not being able to see the chat, but if you guys have any question, I know it's a lot of information. I know I can talk more about specific models. I just want you guys to go home with at least an understanding of what integrated care and collaborative care is, and the examples I gave, especially from a substance use mental health uh, perspective, which is what I do.
We have a few questions and comments. If anyone wants to make specific questions, please use the question and answers because the chat has a lot of comments. The first one would be, we develop a family support group open to any family members or loved ones of an individual battling addiction or alcoholism. I don't know if people is not attending because we are a small community or the stigma behind the addictions. What can we implement to make it work?
So the question is about people not going to the groups and what
Yeah,
can we do to improve that.
yeah.
Okay. And that's that happens. Okay. And I wonder, I mean, I have follow-up questions to that question. Are you guys using any type of technology? Is this like hybrid? Is this mandated treatment? What's the motivation for the patient to go? Is there any incentives? So things like that comes to mind. But motivation depends. I mean, depends on the patient, depends on the cases, how severe they feel the group is bringing anything to them, or they're bringing anything to the group. Ages, gender of the groups has a lot to do. I have a lot of adolescents, for example, that I send to groups, and they don't like it because of the age differences. And of course, the who is running the group has a lot to do too. Are we talking about someone that is a drug counselor and has some experience with drug himself or herself, or is someone that has no experience and they see them as someone that would not understand them? So all those questions, comes to mind when I'm creating a group. Both age group, interest, format of the group. Is it? Are you following a structure, or is it just open-ended questions, more than closed-ended questions? So all that comes to mind. I would say in terms of motivation, talking to the counselor or the therapist, the individual counselor or therapist of that particular patient that's not coming, I think it will help getting the team in the same page of how important it's for them to go to groups. If especially if they don't have like external motivation, like being on probation or parole or any drug court, case is I mean, motivation comes from family or them. I think there's more work to do. I mean, sometimes being on probation or parole helps with their motivations. But I mean, those are the few questions that I would say the team need to ask themselves to improve the group attendance.
Thank you, Dr. Colon. We have another question. What are your thoughts on the barriers for PCPs to provide office-based LAI medications once the client has been stabilized? We often have to serve clients because PCPs, psychiatrists, will see clients who are in LAI and they are stable and leading fairly normal lives.
Yeah, that's a good question. I mean, that's a tough one. Giving injection to people, I mean, a lot of people are not comfortable with. Uh, I think medicine have changed a lot in the last year. I remember when I was in residency, we were crazy about doing injections and procedures. These days, I mean, usually doctors are not don't prefer to do that unless you're a surgeon, right? They don't. I mean, they don't like to give injections. Some injections are hard because they need a special treatment in terms of the injection itself. I mean, some of them need to be on a fridge, and then you cannot get them out for more than 7 days. Some of them are REMS, part of the REMS system, and you need some kind of DEA or talk or have some kind of transportation special for them. Or the patient need to bring it, and sometimes we don't trust the patient, or they don't have a nurse. So it's a lot of confounding factors. Well, I agree. I mean, I think that's why right now we're seeing more of the specialized pharmacies. I think that will help having a good relationship with a specialized pharmacy, so you can refer the patient to those pharmacy and they take care of the injections, and that works in different ways. I mean, because now there are more people following the patient for adherence. So you have the pharmacy team and you have your primary care team or the mental health following the patient. And I agree. I agree. I agree with you. I think this is something that we need to work on, especially when someone is inpatient and they're discharged, and primary care doesn't feel comfortable uh, following up with injection, and then you have a psychiatrist that's new or not seeing the patient in 3 months. I mean, what do we do with these patients? It does help that right now pharmaceuticals are working on longer and longer and longer injections. Like some of them last 6 months these days. So that helps. So I would say if you have someone that misses or primary care doesn't want to do the injection for some reason, I think putting them on a 6-month injectable, finding a good behavioral health professional that do this, I think that will help, or a specialist pharmacy. I think that would do the work. Case manager also, I mean, there are nurses or home cares that do the injections as well. There's a lot of action on the chat. Any other questions? I see people are coming from different states, different areas. That's great. That's great.
Oh, yeah. We have one question.
Sure.
We are Why are we limiting mental health services to evidence-based models such as SFT and CBT that do not take into consideration intergenerational family patterns and do not engage families in treatment? What can be done to challenge the narrow view of mental health treatment within a behavioral care setting?
That's a great question, and that I mean, I agree. I agree. There are so many option models out there now with technology and AI. I mean, that's gonna explode in the future. What we're doing in terms of models and evidence based. I would say the tricky part about off-label things, and the same happen with medication, right? Why we don't use medications more often that are proven to to work, right? We use a lot of off-label medication for indication that, I mean, they're far away from the first FDA approval. The same with therapy, right? We concentrate on CBT, prolonged exposure therapy, and things like that because those are the ones that the insurance want to pay for. And I don't want to create any issues with insurances, but I think that's part of the problem, right? Who is actually running the show, running the situation, and who is getting reimbursed for? I mean, a pretty simple example is CBT, right? You you get paid more, reimbursed. You get reimbursed more if you're doing CBT versus uh, other type of treatments. So if you select CBT versus something that would not pay the same, you will get reimbursed more. For that to change, I think talking to organizations like the APA, for example, will help. I mean, we have a lot of advocacy groups that can help with that. A quick example could be something like what we're doing with the black box for suicide and SSRIs, right? How much that help patients or not help patients is questionable. Do we need to take the black box out to better use SSRIs? So that's a question. Um, so for that, you need to advocate for the change and do research. And it sounds like the research have not found any link in terms of how much helps that having that box for treatment of depression. Um, so similar to your question, I think we need to look for the research, create a position statement or an action paper, and take it to this organization to help to push the change in insurances companies or FDA or things like that. I hope that answered your question. I know it's not an easy fix because it has to do a lot with reimbursements and acceptance of the treatment, and less than what actually helps in terms of treatment, if that makes sense. And
Thank you so much.
there are a lot of family. I mean, there are a lot, there are a lot of family oriented treatment out there. Usually, mostly for adolescents and kids. And I mean, there are a lot that we. I mean, if you email me, I can give you a few. But they're usually targeting adolescents, no adults.
Thank you so much. From a prevention perspective, what are some of key factors affecting our Hispanic population?
I'm sorry. What's the question?
From a prevention perspective, what are some of the key factors affecting the Hispanic population?
From a prevention standpoint, so why we're not doing more prevention in the communities? That's the question, or
No, what is affecting the Hispanic population? That's the question. Like,
what is affecting
yeah,
the Hispanic populations?
yeah,
Well, I mean, a lot. I mean, barriers is one. Workforce is one. A trust in the system is a big one. Uh, I mean, there's a lot of miscommunication for Hispanic communities and any kind of vulnerable population out there. I mean, we saw that in COVID-19. I keep saying COVID-19 because I mean, we're still living on that. And we saw how communities, Black communities and Hispanic communities suffer the most. I mean, we saw how maybe 3 times, risk of dying from COVID in Hispanic and African Americans comparing to Caucasians. And I think that miscommunication has something to do. When we talk about getting information out there, it's not only translating the information in Spanish, is also sending in a cultural component and a cultural humble way. We talk about trauma, generational trauma is a big one. Stigma, racism is a big one. And resources of this family. I mean, we don't Hispanic communities don't participate in research, and so they're not taken in account when we have a new medication. A good example. I mean, you can call any pharmaceutical and ask how many on how many Hispanic you try this medication or this treatment, and they will say probably 0.001%, because they do not. they do not do research of medications in Hispanic, and we expect them to work in our communities. And I challenge you guys to call these pharmaceuticals and ask that question. I mean, how many of your participants were Hispanic? So those are those are barriers that have been around for a long time.
Thank you so much. We have another question. Do you know or foresee change in policy, if any, that will be affecting the Hispanic community healthcare and mental health services with the Trump administration?
Oh, that's a hot topic, and that's something I ask myself like every day since November 5th, 6th. So that's a good question. A quick example will be grants, right, and services. I know there's been a lot of communication or conversation about cutting some services, especially those that are coming from the federal government. I'm not too sure about how active grants are going to be affected, but how maybe they will decrease new grants and cycles of grants like this or loans like this. So I would say in terms of ongoing services, it will be hard for them to stop them versus the creation of new services. I think that will be decreasing. If that makes sense. For example, I have a few grants that are expire in March next year. I guess the question for me would be, okay, how easy will be for me to reapply versus are they going to eliminate these grants? I don't think they're going to be eliminated because they're already active. And I don't think they're going to make it harder to reapply. I think what is going to be affected is a new rounds or new ideas or new resources. I think that will be affected. On the other side, I think the need for treatment is going to be a lot higher during the next administration. So all of you guys are mental health professionals. I mean, just prepare. I mean, I think we're going to be busier.
We don't have any more questions. If someone else wants to send us their questions, we still have a few minutes.
Yeah, I mean, if you have more questions and things like that, or have any idea of how to move this forward, any action paper, position statement, or anything like that, I mean, you can contact Paola, and we can work on something. There are a lot of councils and groups out there working on this. I mean, the Hispanic Medical, it's Hispanic Society or Hispanic Medical Association. Hispanic American Medical Association, I think, has a lot of work on this, and they're pretty good, in terms of advocacy. So that's a good group. The American Psychiatry Association has worked on their first tool in Hispanic in 100 something years. It's called lasaludmental.org, and there's a lot of information there in Spanish. I do support that. I'm the co-chair for content of that webpage. So you can check it out and give me any feedback and what needs to be included and what's needed for our communities. So again, lasaludmental.org. It belongs to the APA, the American Psychiatry Association.
We have one more question. Is there any information about approaches to trauma in collaborative care?
Yeah. So I don't think I can answer that in 1 minute, but so in terms of trauma, yes, there are a few collaborative care models that are trauma focused. It's a little bit harder in terms of, because usually collaborative care and integrated care are general. We're talking about mental health and substance disorder. There is not like a model for a specific one, unless we're talking about a specific, specialized treatment, like the one I put for opioid disorders. I mean, those are specialized in opioid disorders. In terms of trauma, there are a few. I don't know how um, common they are, if that makes sense. I think in terms of that, what it works is, the first assessment is really important. And if the trauma is so bad or it's making, or the patient is not functional, it's debilitating for the patient, I think a referral will be better. So what the collaborative care would do is identify the problem from a primary care setting and help that patient with a treatment plan. And the treatment plan could include focusing in individual therapy versus group therapy for that particular trauma. I mean, and there's trauma and there's trauma, right? I mean, we talk about, and for me, trauma has to be treated and assessed as in single trauma, not like a trauma. I mean, different people have multiple traumas, but there's always one that kind of, decrease functionality and is the creator of most of the problems. So I think with that, we need to, focus on one trauma and refer that patient to a trauma program, if that makes sense. But collaborative care and integrated care would help to identify that problem, work on a treatment plan for that patient, probably around the trauma, and then refer out for a more integrated trauma program.
Thank you so much, Dr. Colon, for your time today. We have more comments and more questions, but for anyone that still have questions, please feel free to reach out to our email or through our website. We will be trying to answer all of your questions.
Yeah,
And
we could do one about AI, a presentation about information AI and technology on this because it's changing. I mean, therapy is changing, and there is a lot of fear about AI. I mean, a lot of excitement, but fear as well about the AI.
mhm. Yeah, so I guess that would be all for today, Dr. Colon. Thank you so much
Of course.
for all of this great information and for everyone to attend today.
Okay. Thank you. Gracias.
Yeah.